for the COVID-19 and SARS-CoV-2 pandemic. And the discussion today, the topic is, are there symptomatic patients? And if there are those patients, what is their role in the spread? Do they, of course, they are asymptomatic, so do they even know that something is happening with them? And number three, why are they asymptomatic? What is the reason that these patients do not know? Is their immune system more strong, or is there some other reason? So we would look into those things as well. So I have a number of studies that we will go through those as well to figure out who are the people who may be asymptomatic. And number two, what is the role in the overall infection or herd immunity as well, and overall spread of the infection. So let's start. Good morning. Okay, so the first thing is that we have, I'm going to share my screen. There are a few studies that I want to show, and there are a few of the mechanisms that I want to discuss as part of this discussion. So let's start that. Hello, Harry. Hello, Rachel. Rachel, how are you? Thank you for joining. Harry, thank you for joining. Let's continue. So the discussion is about the asymptomatic patients. So here is what we are going to talk about today. What are the asymptomatic patients? Is this good or bad? Actually, it is both. And who are the asymptomatic patients? Why are they asymptomatic? How are they good for the society? What is the negative impact? So let's start. So I'm going to share some data as well. So today we are about 2.2 million confirmed cases and about 153,000 deaths. So the pandemic just keeps roaring on. So here, look at this article, and I'll put the links in the description after the lecture is over. So asymptomatic people may be fueling the coronavirus spread. So this is one of the life science discussion here, where they have referred to the Dr. Robert Redfield, director of the CDC, saying that 1 in 4 people of the COVID-19 could be asymptomatic, so 25%. So I'm going to start from here. Let's look at the asymptomatic patients. Look, the patients that can be asymptomatic are, number one, children. About 29% to 47% of the children can be asymptomatic who actually have the disease. And this is the study that we have here. This study is in the Lancet, and what the authors did was they took 36 children who were confirmed to have the disease, and then they and why they were confirmed to have the disease? Because they were either in the outbreak area or they were in contact with the COVID-19 patients. And then they did analysis on their symptoms. And if you see here, either were asymptomatic, 28%, or had acute upper respiratory system symptoms, 19%. So meaning either they appeared as upper respiratory tract infection patients, or they were totally asymptomatic. And so the very first thing that I would like us to start realizing is that within us, amongst us, there are patients, there are people who are asymptomatic and who have the virus and who may be shedding the virus. So children are one. So this is why those countries that have kept the children's schools open while keeping the other parts of the country locked down may have a problem, because the children, when they go to school, if they get infected, they are going to bring that infection back, and they can actually make their teachers infected as well. So this is one. Second set of people who are asymptomatic are something that we are calling presymptomatic, or they are they are about to become symptomatic. What does that mean is this. So I have a couple of studies here. So this is a study done here in the US where they went through the nursing home and they tested the persons in the nursing home, and they found out that out of the population they tested, 57 were asymptomatic, but they became symptomatic in 10 to 13 days after, or 7 days after. So these are, instead of calling them symptomatic, we are calling them pre-symptomatic, that they would develop the infection, but later on. So this is also something that we can say is the incubation time, correct? These patients are in the incubation time. So here, these children, it's not necessary that they were in the incubation. They just did not have the symptoms. And here, the second category are the pre-symptomatic, that they are in the incubation time. And I have been saying this for some time, and some of the people had disagreed with me. I think finally we are reaching that point that it is what I was saying was correct. And that is this. Look, we know that the incubation time of this virus is anywhere from 2 days after the exposure or receiving the virus to 14 days. Of course, there is an outlier of 24 days as well. And the median is 5.1 days. And I'll show you a study where they found that just before they became symptomatic, that is the pre-symptomatic time, couple of days before, they had enough viral load that they were shedding. And I had been saying this, and let me explain what my reason of saying this is. Look, let's say I receive a virus today, and the virus starts replicating in me. I do not have the symptoms yet, but the virus number or the virus load is increasing, correct? Let's say 5 days from now, the 5th day, I develop symptoms. That means the virus load in my body is sufficient that now it is causing the symptoms. 1 day before, I have enough load that I'm going to become sick tomorrow. That load of virus in me is actually getting shed. It is enough for me to shed it. Similarly, a day before is enough for me to shed it. So I have become enough infected. Infected means the replication of the virus. I'm not diseased yet. Disease means that I have developed the problem. So I do not have the disease yet, COVID-19, but I have enough infection in me that I am shedding at least 2 days before the symptoms. So let's look at that study as well. It's actually fascinating. So if we see here, there is a study. This study was done, so pre-symptomatic transmission of SARS-CoV-2. This is a Singapore study. And if you see here, they have taken a few cluster of people. These are the patients who became patients afterwards, but before becoming patients, they did not have symptoms, and they made other people sick around them who then developed symptoms. And when they tracked them, they found out that they were shedding. So an interesting thing here are these graphs. So in these tables, what they have shown is, this is a more interesting one. So the patient become sick here on 23rd. They become symptomatic here on 8th of the March. So 23rd of February, they become sick. 8th of the March, they become symptomatic. And these days, 3rd, 4th, 5th, 6th, and 7th is the time when they were shedding. And they were giving the infection to others. They were spreading the infection. So this is a time which is pre-symptomatic, but this time is filled with the time that they were shedding. So I hope that that is clear. Now, going back to the discussion here, Why were they shedding? I just explained it, correct? So this is another group of people. And these groups of people are found in our nursing home at this time. These are found in other communities as well. So that is two. Then there is another group of people who we call asymptomatic. So there's a question, can your viral load increase significantly when you are exposed to virus for a sustained period of time? So here is a question. Yeah, a viral, if you are exposed, for example, you are a healthcare worker and you are exposed to virus day in and day out, eventually you are going to catch it if you're not wearing the proper protective equipment and not taking care of the protections. If you become infected, then the viral load is really about the virus replicating in you, not further entry of the virus from outside. So meaning if you are exposed to 10 people, it's not that 10 people's dose would somehow increase the viral load in you. The viral load is still based on your own immune system and your own body's response and the replication of the virus inside of your cells. Now, next group of people here are the, what I call, so this is a new term I'm offering here, I'm coining a new term, dysymptomatic. So let me explain what that means. So these are the people who actually have symptoms, but these symptoms are not typical. And I wanted to use the word atypical to mention these symptoms, but we also know that SARS-CoV-2 itself causes atypical pneumonia first and then typical pneumonia. So I did not want to kind of confuse these two terms. So I made up a new term, at least for our discussion here. We'll call them dysymptomatics. And what they are that their symptoms are not typical. What are these symptoms? And I have heard this, and there are so many studies about that as well. Sometimes people just have headache. That's it. Nothing else, just headache. So they don't even think that this is coronavirus. They just think they have headache. Sometimes there are people who just develop GIT symptoms, nausea, vomiting, diarrhea, and they just do not think that this is the virus. Then there are people who just develop fatigue. Nothing else, just fatigue. No cough, no runny nose, no fever, just fatigue, malaise, feeling like beat up. Then, of course, nowadays we are very acutely aware of anosmia and the taste issues or issues with taste. The issues with taste are actually a result of anosmia. Anosmia happens when the viral replication or infection causes the olfactory nerve to start swelling up. And when that starts swelling up, it starts, so let's say this is a nose of the person. This is the olfactory nerve. And the nose starts swelling up. The olfactory nerve starts swelling up and we cannot smell. The taste, remember, has a component called flavor. And flavor is taste plus smell. So when the smell component is gone, the flavor of the products you are eating, they become different. So flavor is something that we say there is an issue with the taste. So virus doesn't do anything with the taste buds or the nerves that are working with the taste. It actually just causes the anosmia, which can then result in a problem with the flavor, which patients then describe as a problem with the taste. So headache, GIT issues, nausea, vomiting, diarrhea, fatigue, anosmia, and there may be other. For example, chills is another, just chills. And chills can then follow by the fever because chills are usually for the fever, but it is possible that the fever is low enough that they did not consider it to be an issue. So these symptoms are actually, they can actually happen with the COVID-19, but we sometimes do not connect the dots. That is why I have put them in this symptomatic category. Again, I'm saying it, this is the term I am coining. It is not a medical term, but I had to somehow classify this group separately because this is another group that may not be aware that they have the infection from COVID-19 and they may be spreading. So this is a very good question. So Muhammad Tahir is saying that, hey, what is the percentage of the symptomatic? So we are going to start looking at what percentages we know and what we do not know. So there is a lot that we do not know. So going back here to the discussion. So if you see here, what do we have? We have children that are truly asymptomatic. There are adults as well that are truly asymptomatic. That means they never developed any symptoms. Then there are presymptomatic who do not have symptoms. They will develop symptoms, but they are shedding in their incubation time. Then there are people who have dysymptomatic, which are, they have atypical symptoms, headache, GIT, fatigue, and those. Then after that, there are folks who have recovered and are now carriers. And I had shown you this study before. So if I go here is a study where they say that patients who had recovered, they showed that they had the virus still present in them. So they had over here in the discussion, they've said that it is possible that some of these patients are carriers here. So recovered patients still may be virus carriers. So this is a study where they're talking about people who have recovered. So they have become asymptomatic. They got the nasal swabs negative and they were sent home. And then 10-15 days after, when they were followed up and another set of tests was done, there was virus there. So there are many reasons that this can happen. For example, this could be a false negative at the time of discharge. So they were really not clear, but the test is not very sensitive. So test said that, yeah, sure, you are clear, but they were not clear and they were sent home and they still had the virus. That is one possible. The second possibility is that when we did the follow-up test, maybe that was a false positive, that they were really not positive and the test said, yeah, you are positive. Third possibility is that there are remnant RNA pieces sitting in their cells and the mucous membranes that we picked up and said, hey, this is a virus, and that really was not a virus. And then fourth possibility is that they are carriers. I have already had this discussion. There is another talk that I've done where we discussed that it is it is a remote possibility. It is a remote possibility that they are reinfected. And I had, in that talk, I had discussed the testing they had done on the rhesus monkeys, which could not be reinfected. And they have done the testing in the previous SARS-CoV, and they have seen that the antibodies stay in our body for about 2 to 3 years. So the immunity our body generates keeps us protected for 2-3 years. So reinfection is really not a possibility in my opinion. Similarly, there was another discussion that is that a reactivation? And I had that discussion as well, that reactivation is also not known with coronaviruses. It may be that this coronavirus somehow mutated enough that now it has started behaving like a virus that can hide in our body and become reactivated. But so far, looking at its genome and family and species, it does not look like it would be reinfected. So either these were false positives or false negative at the time of discharge, or they became carriers. Good. So there are people who are recovered and who may still have a chance to shed. So that is another group. So the groups are now children and adults who are asymptomatic. By design, they are asymptomatic. Their immune system has helped the virus helped their body enough that the virus was suppressed as soon as it came in. So they developed immunity and the virus didn't do anything. So they're totally asymptomatic. And then the other cases are presymptomatic, which are in their incubation time. And then there are people who are dysymptomatic, who have atypical symptoms. And then there are people who are recovered. So all of them are asymptomatic. I believe that we should add one more group over here, and that is newly discharged. And here is why I'm saying it. I don't think that, and I'm not talking about US or any one specific country, I don't think that all healthcare facilities are discharging people based on 2 nasal swabs negative in 24 hours. So I am sure that some healthcare facilities are discharging people who have become asymptomatic, but they're still positive and the virus load is going downwards. And when they go out in the society, they would spread for some more time. Good? So these are the folks who can be asymptomatic. Now let's look at how this can be good or not good. So I'm going to go here, good or bad. I'll give a simple answer first. Simple answer is good and bad both are true. Bad because they become spreaders. Children can be giving it to the others unknowingly. Again, they do not know, they are asymptomatic. So it's not their fault that they are spreaders. They just don't know it. So they can be spreaders, and that is the bad part. The good part is that they become part of the herd immunity. The good part is that they are not dying. The good part is they are not using healthcare facilities. Correct? So there are some good outcomes. However, there is spread from them to the other community members, which can be dangerous. So now let's look at it, that how our community at this time, how it is designed from this virus and pandemics point of view, and what are the people who are sitting in the community and who may be spreading and we do not know, or even if we know, we allow that to happen. So let's look at it. Look, what happens is, so the community dynamics. And of course, this would mean that every community has a different dynamics. Every country has different rules and principles for how they are managing. So it may not be applicable to everyone, but let's start with this. Look, let's say we have a number of people who become symptomatic. Symptomatic, and this is the typical symptoms. That is the symptom of cold, symptom like cold, runny nose or sore throat or dry cough. So they become concerned, and what they do is some of them are mild enough that they're not bothered and they stay out of the medical system, and they would maybe continue to spread. That's one. Second group out of these symptomatic may be nervous enough, they will be worried enough that they would say, hey, we need to be tested, right? And what they would do is they would talk with their healthcare facilities or doctors and say, I have these symptoms, what should I do? And the doctor would say, have you been to any area of outbreak? Or they would say, and this is the WHO guideline, or the doctor would say, or nurse practitioner or physician assistant or nurse, whoever is their healthcare professional, they would say, okay, have you been in contact with a COVID-19 patient? If the answer to both of them is no, then they would stay out as well, right? So now they have the concern, they have the symptoms, they did bother about it, but they are still kept out because, hey, just stay at home and take care of yourself and take some paracetamols and maybe some cough syrup and drink a lot of water and vitamin C and D and you'll be okay. So they may be, if they're not sitting at home, they may be spreaders as well. Then those who said that, hey, I have been in contact with a COVID-19 patient, or I have been in the area of an outbreak, they become the suspected cases. Correct? So suspected cases are then tested, and if the test is positive, then they become the confirmed case. Confirmed case. And we know that out of the confirmed cases, 81% are mild, about 14% are serious, and about 5% are critical. We normally count this population. The count is here. When I say that we have, let's say 10,000 people of coronavirus, we are talking here at this level. We are not talking about this group. We are not talking about this group. And now, one more thing, we are also not talking about a larger group that is dysymptomatic. When I mentioned those symptoms up, again, what is their percentage? That was a question here as well. We do not know yet. There need to be studies to figure out, were they SARS-CoV positive or not. And I'll show you that there are some studies that are happening. Then below them, in the remaining population, there still are those who are truly asymptomatic. And I have mentioned them all in the study above, so I do not want to repeat that, but they're really asymptomatic. Children, adults, then people who have been discharged and they are spreading, or people who have been pre-symptomatic, they do not have any symptoms, and they are in the incubation period and they are spreading. Correct? So they are out here as well. And interestingly, from one study, I got the number of people who may have been infected, recovered by themselves, with or without symptoms, stayed in the society, and that number is usually 50 times to 80 times more than times, X standing for time, more than the confirmed cases. So if I say that somewhere there are 1,000 confirmed cases, in that community, there may be 50 to 80,000 recovered cases or asymptomatic cases. This is a good thing or a bad thing. The good thing is they are part of the herd immunity. They make about 4% of the society or that community. So that means if a society says, let's look at the US, for example, we are more than 500,000 cases now, then take 50 times of that, and that is the number of people who may have already become ill and recovered and developed immunity and become part of the herd immunity. So let me show you that study. It's a fascinating thing. I'm amazed at this. So look at this. Here is a study. So first of all, this is a study in Santa Clara. So this is my county. This study was done in Stanford. I live about 10 minutes from Stanford. So I live in this little town, Cupertino. So I thought I'll take this opportunity to show you where I live. So Cupertino is where I live here. And this is the county, Santa Clara County, for which this study is done. The number of people here are 1.9 million. The population is 1.9 million. Now with this population, thank you and love you too. And back here, there is a study done in Stanford. First, let's look at their disclaimer. They say this article is a preprint and has not been certified by peer review yet. It reports new medical research that has yet to be evaluated and so should not be used to guide clinical practice. So their disclaimer should be in front of us. And here is what they did. In this county, in my county, what they did was they did an antibody test. Look, when we talk about testing, we know that there are two types of tests. There are tests for the swabs, right? So that is the viral RNA, viral, so RT-PCRs, correct? Or RT-PCRs. They look at the viral RNA, and that is looking for an active infection. And the other tests are serum test for antibodies. And these tests are usually positive for recovered patients. And I have done this mechanism, I've discussed this mechanism many times, that when the virus arrives into our body, our macrophages eat it up, then they present it to the T cells. T cell, I'm now just trying to be brief. T cells then in turn would cause the B cells to become activated. So these are the B cells, and B cells would make antibodies. First they will make IgM, and then they will make IgGs. Correct? These antibodies, IgMs and IgGs, are present in our body once we have recovered or once we had the infection for a couple of weeks. So these recovered patients will have the antibodies in them. So this study, what it did was it looked at serum antibodies in volunteers in our county. So they just took people's blood and they looked for the antibodies in them. And they did not ask the people if you are sick or not. The point was to figure out in the community, has the virus been spreading? Have their people been asymptomatic and unknowingly giving it to others and then recovering themselves as well? And what is that percentage? So the time that they did this study, at that time in this county, so county is 1.9 million people. This is the Santa Clara County. So there are 1.9 million people population here. I am one of them. Then what they did was, at the time, they took 3,300 people, and then they did seroconversion test or antibody tests on them. At the time, they did it on 3rd and 4th April. So it is a very recent study. 3rd and 4th April. At that time, in this county, there were 1,100 cases. So now pay attention to this. This is funny. 1.9 million population. They took 3,300 people from there on 3rd and 4th April, and they found out that there were 1,100 cases. So that was a confirmed cases. So that was a smaller percentage of this population, correct? However, when they took these 3,300 people and did the testing on them, they found out that according to the prevalence of the antibodies in them, when they adjusted for the population at that time should have had 50,000 to 80,000 patients or recovered people. That is 50K, 50-fold to 80-fold difference. And these folks, only out of them, 1,100 had ended up in the cases, not even out of them. In addition to them, there were 1,100 more who were in the hospitals or who were confirmed. All the rest were asymptomatic or mildly symptomatic, and they never went and got the help. And now they are part of the society. They have recovered. They have immunoglobulins. So one, they have become part of the herd immunity. Good. That's good. Second, at some point, they were spreaders as well. So this is the interesting thing here. The disclaimer is that it needs to be peer reviewed. It is a preprint. Do not use it for your medical practices. So I would not ask that you start using this to create epidemiological studies from it or projections from it, but this is what they found out. Now, here is another thing. UC Berkeley has just started 5,000 healthy people test for the same exact thing, but what they are doing is a little more sophisticated than this study. They are going to ask for the RNA swab as well. So they're going to see active infected, plus they're going to see people who were infected and have recovered, and we probably never knew. So they are starting that with the 5,000 people. Then in Germany, so here, Germany is also introducing the coronavirus immunity certificates for recovered people. And to do this, what they are going to do is, this is a proposal. What they're going to do is they're going to take 100,000 people and test them. And whoever is immunoglobulin positive, that means they had become sick at some point and recovered, then they are going to give them certificates to go back out. So this is the discussion today. I hope this was interesting. I hope it made sense. The takeaway for me were, number one, there are a lot more people sick or infected than the people we count in the confirmed cases, number one. Number two, that means there are a lot more people who are spreading the disease as well. That means the case fatality rate is lower because the people who are actually infected are 50 times more than the confirmed cases. And we look at the case fatality rate from the confirmed cases. People who died out of the confirmed cases is the case fatality rate. But here, if you actually look at all the people who may have been infected, then the case fatality rate would drop. And then the other good news is they are about 4% of the community, so they are part of the herd immunity. Now, the important thing is for herd immunity with a virus, which we've talked about herd immunity again and again, the reproductive number is 2 to 3. That means anywhere from 50% of the population to 60 to 70% of the population has to become immune to develop the herd immunity, which is a very large number. So maybe we'll have to have vaccines before instead of making people sick. But at least this 4% is becoming part of the herd immunity. So that is the discussion for today. I hope this is interesting and fascinating. We will continue discussing again tomorrow. There are some questions. I'll see if I can answer them. So Brad says, are the epitopes of the IgG similar in the herd? That is a good question. I have not seen the paper yet to see that did they find variation in that. I know where you're going, that are the strains the same. I do not know the answer to that. Great question though. So Kelly says, I take vitamins every day. Is that equivalent? Equivalent to what? But this is important that we keep our immune system healthy and provide the multivitamins to it. Brad, I loved your question. Okay. So thank you very much. There are people who are asymptomatic. Children, 30% of the children could have been sick and spreading, and they do not know it. And then there are people who are actually adults who can be asymptomatic. There are people who are dysymptomatic. That means they have symptoms that they don't think it is the coronavirus. Then there could be very mild symptomatic patient who are just don't bother, the runny nose, nothing, no problem. And then there are people who may have in the incubation period, and then there are people who may have recovered and discharged yet before they fully recovered from the virus load. So that is the discussion today. I've heard that IVIG is helpful in treating COVID patients. So intravenous immunoglobulins, that is a passive immunity. We have done that discussion separately in a talk. Please listen to that. Intravenous IV immunoglobulins are interesting for critical cases who do not have enough time to live if we do not provide them support and develop their own immune response. So to them, you can give passive immunity. Passive immunity stays with a person for about 4 to 6 weeks, then those immunoglobulins degrade. But that may give you enough time to keep the patient alive and stable and their own immune system start responding. So Kelly says, my flatmate was really sick. He tested negative. There's still an influenza running around. Of course, there is actually cold going around as well. So there are possibility of other symptoms as well that look, other diseases that look very similar to these symptoms. All right. So guys, I can't find journal. Please send me in Messenger. No, I would not send it in the Messenger. After the lecture is over, I go and update the description and put all the descriptions in there. So there's a question, what about universal mask wearing and hand hygiene? So Catherine, I have done a lecture about that. We should all wear masks. And I have that lecture. If you look at this list, you would see that there are 2 discussions I've done. One is why should we wear masks, and number two, how do we make masks if we do not have those? So I hope that this was useful. I hope you learned some more with me today. And thank you very much. If there is any mistake I've made, please put that in the comment and correct that and add value to the discussion. There are some folks who become very angry and they start yelling in the comments. I think that is not necessary. We can have a more healthy and disputational dialogue, but add value. So there is a question, what is the probability of getting infected through eyes? Same as the eyes and mouth and nose. Eyes have mucous membrane as well, and so that can easily catch the virus. So how important is it is to wear goggle? Very important. Just like to cover mouth and nose is to cover eyes as well. I've read a story that virus didn't originate in Wuhan at all. So Kelly, that may be a separate discussion. Maybe it didn't. Wuhan was playing with binding ACE2 in a background. I didn't get the question. Lots of fluids. This virus wants to dehydrate. Yes. Lots of fluids. Yes, definitely. So thank you very much, guys, and talk to you tomorrow. We'll continue our discussions. Bye-bye for now.